Autoinflammatory diseases are characterized by fevers and systemic inflammation that can be severe and difficult to treat. These diseases are often found to have genetic causes, leading to an overly active innate immune system. Identifying these genetic causes aids in finding effective therapies and prognosis for patients. A major goal of NHGRI's Inflammatory Diseases Division is to use these genetic findings to provide effective, tailored care for each individual patient. It's particularly difficult to identify genetic causes in adults, hindering our ability to provide comprehensive care. However, VEXAS syndrome was discovered last year as a severe autoinflammatory disorder with adult onset. It stands for vacuoles, E1 enzyme, X-linked, autoinflammatory somatic syndrome. It's caused by somatic mutations in the UBA1 gene within hematopoietic stem cells. Our initial report identified patients with a 40% mortality rate. Across our VEXAS cohort, there is a large amount of clinical heterogeneity, with some patients presenting with severe disease at 40 years to others just beginning mild disease at 70. So far, VEXAS is known to have hematologic and inflammatory manifestations and has no treatment. High steroid doses are the only therapy known to mitigate some symptoms. Given the presentation diversity amongst VEXAS patients, we asked, what are the clinical hallmarks warranting genetic testing, and how can we identify VEXAS patients that may develop more severe disease? We began by examining our expanding cohort to determine the most predictive clinical manifestations and looked to patient variant correlations with disease severity as a biomarker in order to estimate prognosis. Since publication, we've had a 60% positivity rate diagnosing VEXAS, indicating our current clinical description of the syndrome is effectively identifying patients. We can affirm that a combination of vacuolated myeloid precursors, lung infiltrates, bone marrow failures, and systemic inflammation are strongly indicative of VEXAS syndrome. Now, to identify a disease severity biomarker, we looked at the patient variants. We currently know of 3 UBA1 mutations replacing methionine 41 with valine, leucine, or threonine. By examining the percentage of patients within each variant, we determined that valine has a significantly higher mortality rate than the leucine or threonine variants. This biomarker will help identify patients in need of a more aggressive therapeutic approach and provide a more accurate prognosis. To conclude, our outlined clinical hallmarks of VEXAS syndrome and variant biomarker will help improve diagnosis and comprehensive care. Thank you.